Picture this. A man is 71 years old, completely retired, sharp as ever, still mowing his own expansive lawn every weekend, still driving himself to his competitive Tuesday night poker games. His wife finally convinces him to come in for a comprehensive physical examination that he has been stubbornly postponing for over 2 years. Dr. Harold Meyers looks him over, checks his vitals, smiles, and says everything seems absolutely fine. Then he adds 6 simple words that change everything, changing the trajectory of this man's entire life. Let us just run a few tests. Exactly 3 months later, that very same man is slowly recovering in a hospital bed from a complex medical procedure he never actually needed for a silent condition that would never have affected his health or his lifespan. He is dealing with severe draining complications that have absolutely nothing to do with the reason he originally walked into the medical office, and the version of his life he had right before that routine appointment, the beautiful lawn, the weekly poker games, his hard-earned independence, that version is permanently gone. That tragic story is not rare. That specific story has an official name in the peer-reviewed medical literature. And today, we are going to talk about it honestly, pulling back the curtain on how modern medicine handles aging. My name is Dr. Harold Meyers. I am a practicing physician specializing deeply in cardiovascular health and the intricate science of aging. What I focus on specifically in my research and clinical practice is how the human body's circulatory system and structural organs change fundamentally after the age of 60, and what that means for how we must make safe medical decisions. In my years of intensive work with adults over the age of 60, the frustrating pattern I keep seeing over and over is this. People who felt perfectly fine, completely healthy and vibrant going into a routine checkup appointment and came out the other side dealing with a severe medical crisis they never had before the testing process even began. That pattern has a distinct physical mechanism. It has a well-documented name, and once you truly understand how it works, you will never sit in a doctor's office the same way ever again. Here is the terrifying number that should stop you dead in your tracks. Peer-reviewed studies estimate that between 15 and 25% of all medical procedures performed in the United States every single year are completely unnecessary. But here is the critical part nobody talks about in the waiting room. That percentage rises sharply, almost exponentially, after the age of 65. Not because older patients are suddenly sicker, but because the risk-to-benefit equation changes completely and fundamentally after you cross 65. And the truth is, the modern medical system was never designed to accurately calculate that complex equation during a standard rushed 15-minute appointment. There is an aggressive phenomenon called the medical cascade effect. It works like a row of falling dominoes. One routine screening test finds a tiny, meaningless abnormality. That abnormality automatically triggers a follow-up diagnostic scan. The scan suggests something unclear and recommends an invasive biopsy. The biopsy leads to an aggressive surgical procedure. The procedure inevitably causes a serious clinical complication, and a person who originally walked in feeling completely fine is now permanently managing a chronic medical situation they did not have before they agreed to that very first routine test. The dangerous cascade does not begin with the major surgery. It begins with the pen stroke on the first innocent test. And that is exactly what today is about. I am going to walk you through 5 specific medical checkups and standard screenings that I would personally reconsider and deeply question after the age of 65. Not because modern medicine is broken or inherently malicious, but because after 65, the risk-to-benefit equation changes entirely. And very few doctors are discussing that shifting equation openly or transparently with you. I will show you precisely why it changes, what I have seen happen to real-world patients in my career, and I will give you a set of specific, powerful questions at the end of this video that can completely change the conversation during your next medical appointment. Stay with me through all 5 of these screenings because each one reveals a different hidden flaw in modern healthcare. Number 3 on our list is the one that surprises people the most because it involves a test that sounds like pure, undeniable common sense. And number 1, the final one on our list, is the checkup that almost nobody in the world is questioning, even though the data behind it is more troubling, more dangerous, and more statistically definitive than almost anything else on this list. Before we dive into the details, I want you to leave your city or state in the comments right now. I personally read every single one of them, and I genuinely want to know who is watching this video and engaging with this message. It means a great deal to me to see the incredible global community that has grown around this channel. But first, there is one foundational concept you must understand deeply, because without it, nothing else I say today will fully resonate with you. I call this concept the longevity lens. Here is exactly how it works. When you are 50 years old, routine preventive screening is often one of the single best financial and physical investments you can ever make in your long-term health. You identify a dangerous problem early, treat it quickly, and potentially gain 30 or 40 more healthy, active years of life. The equation is straightforward. The investment pays off beautifully. However, after the age of 65, 3 things fundamentally and permanently alter that equation. First, many of the asymptomatic conditions that routine screening identifies in adults over 65 will never actually cause a single day of harm. They grow incredibly slowly. They produce absolutely no physical symptoms, and in a significant number of cases, you will simply outlive them. But once a strange result appears on an official medical report, modern medicine does not have a functional leave it alone button. It has an aggressive treatment button, and that button almost always gets pressed by default. Second, your aging body's baseline tolerance for aggressive medical intervention is simply not what it was when you were 50. A major surgery that a 58-year-old completely recovers from in 2 weeks can mean months of painful recovery for a 73-year-old, frequently bringing along unexpected hospital-acquired infections, permanent loss of physical independence, and a baseline quality of life that may look devastatingly different afterward. Third, there is that relentless cascade effect. One test, one minor abnormality, one inescapable chain of events that began from a place of feeling perfectly fine. Keep that longevity lens firmly in mind as we go through every single item on this list. All right, let us get right into the details, starting with number 5 on our list. Checkup number 5 is the routine PSA prostate test after the age of 70 in low-risk men who have absolutely no symptoms. This specific screening requires immense precision because it is incredibly easy to misunderstand. I am absolutely not saying that prostate cancer is not a real disease. I am not saying that PSA testing has no clinical value whatsoever. What I am saying is that for men over the age of 70 who have no current physical symptoms, no strong family history of early disease, and no prior medical concerns, the statistical data on routine PSA testing tells a story that most men sitting in Dr. Harold Meyers' office have never been told by their primary care doctors. Here is the core biological issue. A highly sensitive PSA test can easily detect a prostate cancer that is, biologically speaking, barely moving at all. It detects a slow-growing tumor that, if left entirely alone, would never spread to the bones, never cause urinary symptoms, and in a 71-year-old man would almost certainly never shorten his natural life by a single day. He would live comfortably with it, not die from it. But the exact moment that lab result comes back from the facility, even slightly elevated, modern medicine does not wait around to see what happens. Expensive biopsies are ordered, multiple specialized urologists are consulted, complex treatment options are urgently presented, and for a man who is 71 and otherwise incredibly healthy, active treatment for low-grade prostate cancer can mean invasive radiation, intense hormone therapy, or major surgery, each carrying massive permanent risks to urinary continence, sexual function, overall energy levels, and his complete daily quality of life. The American Cancer Society explicitly updated its formal guidance specifically because of this systemic issue. For men with less than a 10-year life expectancy, or for older men at average risk who have zero symptoms, the physical risks of finding and treating a slow-growing cancer frequently and heavily outweigh any potential statistical benefits. I want to tell you about a real patient named Raymond. Raymond is 74 years old, a proudly retired electrician from Tulsa, Oklahoma. He was incredibly fit, walked daily, had absolutely no family history of prostate cancer, and absolutely no urinary symptoms of any kind. His routine PSA test came back slightly elevated during his annual physical examination, a test his doctor ordered automatically. A subsequent painful biopsy confirmed a low-grade, slow-growing prostate cancer with a Gleason score of 6, which in medical terms means it is about as slow-moving and harmless as a prostate cancer can possibly be. His urologist, following standard hospital protocols, recommended full radiation therapy. Raymond trusted the professional recommendation completely and proceeded with the treatment sessions. Within 8 months of finishing, he was dealing with chronic, overwhelming fatigue that disrupted his active mornings, severe urinary urgency that completely changed how he lived each day, and a quality of life that had declined in ways he never could have anticipated before walking into that clinic. When he sat down with Dr. Harold Meyers 1 year after his treatment, the words he used were heartbreaking. He said, "I felt so much better before they found it than I do now that they fixed it." That exact sentence is not rare. It appears throughout the medical literature with a haunting consistency that should give every single man over the age of 70 serious pause before automatically agreeing to a routine PSA test. So, what should you do instead? If you are experiencing real urinary symptoms, such as hesitation, sudden changes in your urinary flow, or significantly increased frequency at night, talk to your doctor immediately. Those symptoms matter immensely. If you have a strong multi-generational family history of early prostate cancer, that completely changes the risk equation. But if you are over 70, have zero symptoms, and are considered average risk, the conversation with your doctor should not be about whether to screen. The conversation should be, what would we actually do if we found a low-grade abnormality? And would that treatment improve my life more than simply monitoring the condition carefully over time? That question alone often changes everything about your care. Now, let us move directly to checkup number 4 on our list. Checkup number 4 is the routine bone density DEXA screening, followed by an automatic, long-term prescription of medication. Before anyone misunderstands or misinterprets this section, let me state clearly that osteoporosis is a very real disease. Falls can be completely devastating for older adults, often leading to a rapid decline. I want to be extremely precise here because there is a massive clinical difference between questioning the necessity of a screening test and questioning the automatic, aggressive treatment pathway that often follows that test without nuance. A standard DEXA scan measures your bone mineral density. If the results show a bone density that is technically below an arbitrary statistical baseline, many physicians will immediately prescribe a class of powerful medications known as bisphosphonates, including popular brands like Fosamax, Beniva, and Actinol. You have probably seen these names plastered all over television advertisements. The message in those ads is simple and persuasive. Low bone density equals medication, and medication equals complete protection from fractures. But here is the critical part that those marketing messages and brief doctor appointments often leave out entirely. Long-term bisphosphonate use, particularly when it extends beyond 5 years, has been scientifically associated with a rare but serious condition known as atypical femoral fractures. These are severe stress fractures of the thick thigh bone, which ironically is the very bone the treatment is intended to protect. These fractures can happen without warning while simply walking, are incredibly severe, always require major orthopedic surgery, and in many tragic cases create far more permanent disability than the minor fracture they were originally prescribed to prevent. There is also a well-documented condition called osteonecrosis of the jaw. This involves a horrific deterioration of the jawbone tissue that can be immensely painful, incredibly difficult to heal, and in some cases is triggered directly by the very medication intended to strengthen the skeletal system. Meanwhile, and this is the vital part that should be included in every single discussion about bone health in older adults, the single most effective intervention for reducing actual fractures in adults over 65 is not necessarily a powerful chemical medication. It is comprehensive fall prevention and intensive balance training. Rigorous research on Tai Chi in particular has shown that it can reduce an older adult's fall risk by nearly 50%. Removing hidden tripping hazards from the home, installing sturdy grab bars in bathrooms, reviewing all daily medications that may cause sudden dizziness, and having your vision checked carefully every year are interventions that often reduce actual fracture risk far more effectively than many prescription medications, and they do so with absolutely zero medication-related side effects or physiological complications. Let me tell you about Gloria. Gloria is 72 years old, a retired elementary school teacher from Phoenix, Arizona. After her regular annual physical examination, she underwent a routine DEXA scan and was told that her bone density was technically below normal for her age range. Her physician prescribed a strong bisphosphonate the very same day and advised her to continue taking it indefinitely to protect her hips. Gloria came to see Dr. Harold Meyers 3 years later after developing a persistent, deep aching sensation in her right thigh that made walking difficult. Further evaluation revealed an early atypical stress fracture. She had never experienced a single fall. She had no history of bone fractures. She was faithfully taking a medication intended to prevent fractures, and yet her bone was reacting adversely to that very treatment. So what should you ask before automatically starting a powerful medication based on a scan? You should ask your doctor, what is my actual real-world fracture risk based on my complete health profile, muscle strength, and history, not just this isolated scan result? And can we thoroughly compare the potential benefits of this medication with the proven benefits of a structured fall prevention and strength program? That question is neither difficult nor confrontational. Any good, compassionate physician should welcome it openly. Now let us move along to checkup number 3 on our list. Checkup number 3 is routine cardiac stress testing in people who have absolutely no symptoms. This is the specific screening that surprises many people the most because it sounds incredibly responsible and proactive on the surface. Your doctor looks at your file and says, "You are 68 years old. Let us just make sure your heart is doing okay before you start traveling or exercising more." You get on a moving treadmill, or they administer a potent intravenous medication that temporarily stresses your heart muscle, while they monitor how your cardiovascular system responds on an electrocardiogram. What could possibly be wrong with that? Here is the massive problem that almost no one discusses inside the examination room. Cardiac stress tests performed on people who have absolutely no physical symptoms, meaning no chest pain, no unexplained shortness of breath, and no dizziness during physical exertion, can have false positive rates approaching 40% in certain age populations. That means that in nearly half of those cases, the test falsely identifies a dangerous abnormality, even though the patient's heart is actually functioning normally and safely. But modern medicine cannot simply ignore an abnormal test result on paper. That false alarm often pushes you forcefully into the next stage of the dangerous medical cascade, which is an invasive cardiac catheterization. A thin, flexible tube is threaded through your blood vessels, usually through the wrist or the groin, and guided directly into the chambers of the heart. The risks of this invasive procedure include severe bleeding, permanent blood vessel damage, acute heart rhythm disturbances, and in rare cases, the catheterization itself can actually trigger the very cardiac event or heart attack the screening was originally intended to prevent. And if the catheterization discovers a partial blockage in an artery, which is extremely common among perfectly healthy adults over the age of 65, including millions of people who may live for decades without a single cardiac event, you will likely be advised to receive a coronary stent immediately. Now, this is the part I really want you to hear and understand deeply. Multiple major, multi-center clinical trials, including the famous ischemia trial, which was one of the largest and most rigorous studies of its kind in medical history, found that placing stents in patients with stable coronary artery disease did not reduce heart attacks or extend life expectancy when compared with conservative medication and lifestyle management alone. The invasive stent did not outperform a simple 30-minute daily walk combined with appropriate medical therapy. However, it carried all of the immediate procedural risks of surgery and often required years of intense blood-thinning medication afterward, which brings its own risks of internal bleeding. So the medical cascade often looks precisely like this: feeling completely fine, agreeing to a routine stress test, receiving a false positive result, undergoing an invasive cardiac catheterization, getting a stent placed, taking lifelong blood thinners, and undergoing ongoing monitoring, all with absolutely no statistically significant improvement in your long-term health outcomes. That is the complete unfiltered picture, and it all began simply because someone in a white coat said, "Let us just check. If you are finding this critical information valuable and eye-opening, type the number 3 in the comments right now. It is a simple, quick way to let me know you are following along closely, and it genuinely helps this channel reach more people who may benefit from this life-changing information." So what should you do instead of rushing into a stress test? If you have no chest pain, no unexplained shortness of breath, and no dizziness during physical activity, the conversation with your doctor should not primarily focus on stress testing. It should focus intensively on optimizing the controllable factors that actually drive real cardiovascular risk. This means managing your blood pressure, tracking your cholesterol fractions, monitoring blood sugar, maintaining daily physical activity, and prioritizing high sleep quality. That is where the greatest cardiovascular gains occur after the age of 65, and none of them require a dangerous catheterization to achieve. Now let us move forward to checkup number 2 on our list. Checkup number 2 is the routine carotid artery ultrasound in asymptomatic patients. Almost nobody in the public sphere is talking about this specific test, and based on what the scientific evidence shows, that silence may be one of the most significant oversights in routine senior healthcare today. A carotid artery ultrasound examines the large blood vessels located in the neck that carry oxygen-rich blood directly from the heart to the brain. The concept sounds incredibly logical to a patient. Identify a partial blockage before it can cause a devastating stroke, surgically remove that blockage, and the problem is solved. But the physical reality is considerably more complicated, and for people without any active symptoms, potentially far more dangerous than it sounds. Here is the medical fact that changes everything about this test. The invasive surgical procedure commonly used to treat carotid artery narrowing, known as a carotid endarterectomy, carries approximately a 2 to 3% risk of actually causing a major stroke during or immediately after the procedure itself. In older adults with additional minor health conditions, that surgical risk may be even higher. The United States Preventive Services Task Force, the independent organization widely regarded as the absolute gold standard for clinical screening recommendations in the United States, specifically advises against routine carotid artery ultrasound screening in adults who have no symptoms. Their official conclusion is straightforward and clear. For asymptomatic individuals, the physical risks associated with this surgical intervention generally outweigh the potential preventative benefits. Here is why this happens. A substantial proportion of all adults over the age of 65 have some minor degree of carotid artery narrowing or plaque buildup. In many cases, that narrowing has existed safely for years. It remains perfectly stable, it remains entirely silent, and it never causes any neurological problems. But when a routine screening ultrasound detects it, a well-intentioned specialist may feel compelled to recommend fixing it surgically. The problem is that a surgery performed on a stable blockage that was never causing symptoms can easily dislodge a small fragment of that plaque. That tiny fragment may travel directly with the blood flow into the brain. The medical intervention ends up causing the exact catastrophic outcome it was intended to prevent. So what should you do instead if you have no neurological symptoms, meaning no sudden vision changes, no facial drooping, no arm or leg weakness, no brief episodes of unexplained confusion, and no sudden episodes of slurred speech? Routine carotid artery screening is generally not recommended by experts and should absolutely not be your primary focus. Your valuable attention should be directed instead toward aggressively managing the lifestyle factors that genuinely increase your overall stroke risk, with blood pressure management being the single most important one, followed by blood sugar control, managing atrial fibrillation if it applies to your health profile, and maintaining consistent physical activity. However, if you ever experience any of the neurological symptoms I just mentioned, even briefly, even if they disappear completely after a few seconds, that changes the clinical situation entirely. Seek emergency medical evaluation immediately. At that point, we are no longer discussing routine preventive screening. We are talking about your body sending an active warning signal that deserves urgent, immediate attention. Now, we finally arrive at checkup number 1 on our list. Checkup number 1 is the routine colonoscopy after the age of 75 in low-risk, asymptomatic adults. This is the big one, the specific screening that most people have never heard challenged because colonoscopies have been so thoroughly and aggressively endorsed by public health campaigns for so many years that questioning them in any context can feel almost counterintuitive and scary. But the hard scientific data for adults over the age of 75, specifically those with no current symptoms, a history of previous completely clean colonoscopies, and no family history of colon cancer, tells a vastly different story than most people have heard. The United States Preventive Services Task Force explicitly recommends against routine colonoscopy screening in average-risk adults over the age of 75. Their reasoning is not vague or theoretical. At that age, the procedural risks begin to heavily outweigh the benefits. And those risks become very real when you understand what can actually go wrong during the procedure. A bowel perforation, which is a literal tear in the delicate wall of the colon caused by the scope, occurs in approximately 1 out of every 500 colonoscopies performed on older adults. For a younger, resilient adult, that may be a manageable surgical complication with a quick recovery. For a 77-year-old, it can easily mean major emergency surgery, a temporary or permanent colostomy bag, prolonged hospitalization in the intensive care unit, and a painful recovery process that permanently destroys their independence and overall quality of life. And that is not even including the grueling preparation process itself, the intense bowel cleansing solution required to be consumed the night before the procedure can cause dangerous, rapid dehydration, severe electrolyte imbalances, and significant acute cardiovascular stress in older adults. There is also the inherent risk associated with deep sedation and anesthesia, a risk that increases significantly with every year of age.